We're live.
We are. I look like I'm in Lilliput. I look very tiny to me. Good morning, dear Dr. Rosensweet.
Good morning, Carolyn.
How are you doing?
Good.
That is good to hear. Well, I guess I'm going to welcome us both to our own show and everybody else who's going to be coming up. It's exciting because, I don't know, I missed you. I haven't seen you in, like, it seems forever.
Right, yes.
Let me turn this up and we're going to get to our questions because I know this first one I think you're going to like because we get it. Something you talk of often, are passionate about. Let me begin. Number one, Dr. Rosensweet, do you think it is possible to survive menopause without taking hormones, or is this just an illusion?
That's a good way to put it.
I had to put that part in.
No, I like that. I like how it's being phrased there. Of course, it's possible. There's at the peak of treatment of women in the United States with hormones, which would be 2002, where there was 40% of American women were being treated with hormones. That's the absolute maximum. Might be 7 million these days. At the peak, 40% were being treated and 60% were not. And there was a lot of survival going on there.
Thank you, God.
And then the bigger issue is, what was the quality of life? And these hormones are so powerful. Testicular hormones in men. Man loses his testosterone, loses so much, loses muscle, loses erectile function, loses brain clarity, loses mood, on and on and on and on and on. These hormones are so
someone you
powerful.
Want to get to know really well. Oy vey.
And then for women, we're talking 4 hormones there that the ovaries are putting out. And when a woman loses her testosterone, for example, which is not a male hormone, it's a human hormone, it's as vitally crucial to women as any hormone.
Yes.
And when she loses her testosterone, she loses her drive, her libido. And very often, of course, libido is very complex. There's a lot of moving parts to libido. But most important, when she loses her testosterone, she loses her muscles. And, many women start to identify it even in their 50s when they're getting flab here in this tricep. Yeah. There's loss of muscle there, or they might notice that they're having a more challenging time getting off the floor if they're on the floor, or they may even have to use their arms to help themselves get out of a chair. They're starting to notice and feel the loss of muscle. Well, that progresses their whole life. And it leads to canes and walkers and wheelchairs. And there's a humongous industry in the United States called assisted living facilities and nursing homes. And women can cross over from when they can take care of themselves or their family can take care of them at home to where they can't take care of themselves.
Right.
And one of the things is that they lose bladder control. So many do. If you go to a local supermarket or big box pharmacy, you'll see there's a lot of real estate, a lot of shelf real estate devoted to adult diapers, because women often lose control of their bladders, and they do so because the muscle that holds up the bladder and the uterus and a lot of the pelvic contents, the levator ani, you can identify that muscle by squeezing your anus right now. Let's all squeeze together.
Do you have music? Do you have any music for us?
Squeeze.
Thank you.
That muscle, as you start to lose that muscle through a process called sarcopenia, muscle loss, you can't control your urine as well. And when you couple that with the losses to the vagina and irritating the urethral meatus, the outflow of the bladder, as it goes into the vagina, this is how there is such a phenomenal epidemic of adult diapers.
May I ask you one question?
Sure.
With the urethral meatus, would that also lend to urinary tract infections?
Yes, absolutely.
Thank you.
It's not healthy. It's not a healthy situation. It's an irritated situation because the tube that goes from the bladder and eventually leads to a woman urinating. Well, the urinating outlet is actually in the tip of the vagina there. And it's called the urethral meatus. And if you use a mirror, you can see it. And it can get irritated. And that can lead to urinary frequency. It can lead to inability to totally control your urine. It can lead to recurrent bladder infections, or at least you think you're getting a bladder infection, but you do a urinalysis and it's not an infection. But you can get inflammation there because the vagina is not as healthy as it was when you have adequate estrogens. The big one, and you say, can you survive? Yes. But I was discussing with Dr. Berkson one day. We were trying to get an idea of what percentage of those who move into assisted living facilities and nursing homes are there because of loss of hormones. We think it's huge. We don't know the number, but a lot of women are in nursing homes because they lose cognitive function. And a lot of those women who lose cognitive function, it's primarily dependent on losing estrogen. And if you restore the estrogen in a lot of these women, they'll get their cognitive function back. There's other causes of loss of the ability to think and remember. So I don't want to, for a moment, attribute it all to estrogens, but to a lot of women it is. And I've told stories on this on our morning Facebook Live about a doctor who told me a very personal story about she was losing her cognition at the age of 55. Her mom had dementia. Her aunt had dementia. And she was losing her ability. She said, I'm going to have to quit practice. And she started taking estrogen and kept taking estrogen, kept on increasing, and kept getting clearer and clearer and clearer. Got her mind back. I met her when she was 65. Sharp as a tack. She knows what estrogen role can play in cognition.
There are a few women that we've seen here who have been taking estrogen for quite some time that are of a certain age that we will not mention, that are absolutely gorgeous, amazing, beautiful, vital, happy. Yeah?
Yeah.
Yeah.
And I didn't even mention things like the coronary arteries. Half the women who leave the planet Earth, half the men who leave the planet Earth do so because of a atherosclerosis, a complication of atherosclerosis, heart attack or stroke. Well, young women have protection of those coronary arteries from estrogen.
Right.
And so they have much less of an incidence of atherosclerosis and heart attack than young men of the same age. You don't hear of a young woman having a heart attack at the age of 40, never sick a day in her life, but you do, young men, occasionally.
Yes, you do.
Even those young men, many of them have too low estrogen. Well, do men have estrogen? Well, yes, they do. You don't want to have too much, but you don't want to have them too little either, because they need the protection for those arteries as well. So can you survive? I think it's a question. You may not be thinking and walking, and your mood may be tanked, and you may not be sleeping, as is so prevalent, because these hormones are so powerful. When you lose, it's very difficult to detect a vitamin B6 deficiency, but you can. If you have a chronic depletion of vitamin B6, it's going to show up as symptoms, but they're fairly subtle at first. And then anyone who's eating, in America, it's hard for them to run into major vitamin deficiencies. But you do detect it. 75% of the women who go into menopause It is a shocking and challenging and life disruptive experience to lose those hormones.
No doubt.
And you know, they're the ones that I think are in the best situation because they're having raucous symptoms. They are highly motivated to go, what's going on here? I got to do something about this. 25% of women don't have the symptoms, but they're undergoing the same bone loss, the same muscle loss. I didn't mention bone loss before. The same cognitive challenges. They're just subtle and deeper, and sometimes those women who aren't having these raucous hot flashes and sleep disturbance, they're looking around, they're going, what the heck's wrong with everybody? Menopause is a piece of cake. No, not true.
So well said.
Yes, I know women in their late 80s that to them, menopause is nothing. Their period stopped. And I have a first degree relative who lost her ability to think. And that was the main thing that put her into a nursing home, an assisted living facility. But she also lost bladder control. She also lost muscle. She spent years in a wheelchair simply because she lost muscle strength. One of the tests we do when we're interviewing a 59-year-old or a 55-year-old or a 50-year-old, and I'm on a consultation with them, I say, why don't you stand up while you're in your chair, but don't use your hands. Just stand up. Let me see you do that. You're going to see a lot of strain to do that, where a 20-year-old, they leap off the chair.
They're not even thinking about it.
They're not thinking about it. So can you survive? Possible. I say possible. I didn't say yes, of course. No, because you lose your estrogen and you spend 10 years without estrogen, for example, and we are delighted and happy and to treat you in the menopause method. However, we want to put you through some studies to make sure that in those 10 years you did not get such deterioration of your coronary arteries that you got a clot in there. We want to test your coagulation. It's a much more extensive and expensive process. If you've been 10 years without hormones, why? Because the coronary arteries are so vulnerable. I'm trying to give you the medical curse. Just because you're in menopause doesn't mean that you have arteriosclerosis.
Right.
And, you know, occasionally you see women in their 90s climbing mountains. And they've never been on hormones, but it ain't too common. And I lived a block away from Florida Beach for 20 years. And one of the things that really stood out to me is you didn't see a lot of older folks walking that beach, even though Florida is known for a much higher percentage of older folks than younger folks. It's radical.
Legs were smaller.
And their thighs were thinner.
Yeah.
If they weren't overweight, their thighs were a lot thinner. So, can you survive? Possibly.
I'm wondering
if you're going to want to have intercourse with your beloved spouse. Let me throw a few things out like that, or you're not going to care anymore.
I think it, yeah. Well, it speaks for itself.
So the list is long. Google symptoms of menopause. And there's the ones that you can detect and the ones that are the most troublesome. And for someone who's treated women in menopause for 25 years, I can tell you, my attention is on what the women really want. And they don't know what they want because they don't know what can happen to them in 10 years, 20 years. They're very concerned about the sleep disturbance, the mood alteration, the loss of libido, the vaginal issues. But we're going into the bones because we know what happens to the bones. You lose bone. We know what happens to the muscle over time. So because I've treated women of all ages, I know what a woman's really going to want. When she's 90 years old, she's going to want to go, wow, I'm still doing good. I'm thinking clearly. I love my partner. I'm having active sexual intercourse if they want that. I'm walking them. I'm doing my daily walk. I'm active in my garden. I'm able to get down the ground with my great grandchildren and play with them on the floor where they want to be. Hey, I'm having fun.
Why not?
I'm going to assert that it's almost certain you're going to need hormones to do that.
So it's not an illusion.
Yeah, it's you want to get those hormones replenished as soon as you can and take them for the whole rest of your life, just like I do. Da, 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 da.
I have something very similar to that bottle, oddly.
You do.
I have 3 of them, actually, to be honest. Yes, and I love them. Life-changing.
So there you go.
Thank you, Dr. Rosensweet. It's an excellent.
This is the most important thing. And of course, you really gravitated to this. And this is the most important thing. Your life is going to matter as much to you when you're 60, 70, 80, 90. How well you function. It's going to matter as much to you then as your life does to you in this very moment. And I can promise you, you're going to want to have as much rigorous function as you possibly can sustain. And I'm going to make a strong assertion here. 95% of you are going to need hormones to do so. You're going to need hormone replenishment to do it.
Yeah, I'm not going to go down the road I was just going to go down, but maybe next interview. I thank you. I thank you so much for that, because I sadly do see some of this where I live. I have to keep my mouth shut unless someone comes to me, but boy, it's hard to do, you know? Nevertheless, thank you for that. And we'll move on to question number 2, which has to do with a woman who is taking NP thyroid, and she's taking it along with compounded bioidentical hormones, but she's absolutely exhausted all the time, she says. And I'm wondering, she says, if this is due to an imbalance with the thyroid hormone medication, or maybe an imbalance with it along with the hormones. It's so confusing to me, but I don't feel well. I'm exhausted all the time, and I just don't know what's going on, and I'm wondering if you might.
Well, there's a long list of symptoms that can occur in a menopausal age, and all kinds of stuff. Intractable pain, needing very heavy, intense pain management, joint pain, cognitive issues. The list is very long. And what we teach our physicians and our nurse practitioners and our prescribing clinical or advising clinical compounding pharmacists is treat the menopause first and see what's left. And you'll be surprised. So many of the long list of symptoms can be alleviated simply by getting the hormones, correct. Oops. The field of treating women in menopause with hormones is a very unusual field in menopause, in medicine. It's different than almost any other. As I left medical school and as the years progressed, I started seeing this thing called increasing specialization. There was specialization always. There were surgeons, there was internal medicine doctors, and then there became heart surgeons and brain surgeons and bone surgeons. General practitioners used to set bones. Not such a great thing. The bone surgeons, orthopedic surgeons, they go to, I think, 3, and please someone correct me if I'm wrong, they go to internship, 3 years of surgical residency, a couple years of orthopedic residency. Some of them even specialize in hips and stuff. These people don't get off the ground into private practice until their 30s.
I've said it.
3, 4, 5, 6, 7, 8, 9, 10 years of training, residency programs where they're being taught and they're being mentored. That means they're spending years going on rounds in the morning. And who's on the rounds? The juniors, the medical students, the internists, and then there's the specialty residents and the chief resident and the staff people. These are physicians who have had years and years and years of experience. They're the teachers, and they're going on rounds, and they're doing it every morning, or they're having grand rounds.
Bless, yes.
Having grand rounds. We just had our grand rounds yesterday for the menopause method. The exposure is for years, and this wheel's been invented. It's a great training program. And by the time they're out there on their own in private practice, man, have they seen the patients. They participated in so many bone settings and hip replacements and stuff. If you're an orthopedic surgeon, or the or if you're an internist and you've done time in the coronary care unit, you've seen so many heart attacks, you've seen so many arteries, you've seen it's just outrageous. You name it, there's specialization everywhere in menopause. In medicine. I could say.
Well, you're actually making a really great affirmation there, because it is a specialty, is it not?
No, it menopause isn't. That's the problem. It got this whole treatment of women in menopause got severely stunted. It didn't do what happened in all these other specialties.
Yeah, right.
The Women's Health Initiative false study, scared everybody that if women took hormones, they're going to get breast cancer. The opposite is true. Women who are treated with hormones, even Premarin and Prempro. We had a question on Prempro this morning.
Yes, right there.
Even women who are treated with Prempro, they did a lot better than their contemporaries who weren't being treated in so many ways, including they have a less incidence of breast cancer. The original report was wrong. It was statistically insignificant in the original report. And in 2017, the same study committee that put out the Women's Health Initiative retracted it. Basically a retraction. They printed it in the same journal of the American Medical Association that after 18 years of follow-up, there is no increased risk of breast cancer, heart attack, and stroke. Even in the original report, it was statistically insignificant with Prempro. But no one caught on to that because they didn't understand how to read a science paper. I had to take a 6-month course in a medical school to be able to understand how to read and interpret scientific papers, which are so important, yet there's a bunch of junk out there. And it was junk that stunted they never developed a specialty. I'm one of the few specialists I know. They're out there, but they're rare. Usually people who are treating women in menopause with hormones have got these broad-based practice, and treating women with hormones is very small, and there is no standard of care. There is no board specialization. Our team is working on that. We're trying to create that. We want a board, just like a neurologist is a board-certified specialist.
Can we get a board-certified menopause specialist?
Well, we want to, but we're a ways away from that if we're going to be able to pull it off at all. So this is, what's my point here? Gee whiz, this is not the same. And what it translates for women is, you need to go shopping. If you're in menopause, you want to go shopping. You want to interview a lot of office managers. You want to ask, does your doctor treat women in menopause? Does your doctor specialize in that? Has your doctor had specialized education? Does your doctor use compounded bioidentical hormones? Oh, here's a tricky one to ask. Does your doctor do the 24-hour urine hormone test? The 24-hour urine hormone test? The 24-hour urine hormone test? Notice what I say, 24-hour urine hormone test. I didn't say other urine tests.
Yeah, right. But what if the doctor says, no, you don't need that. I mean, we do blood. It's fine.
Yeah. Well, you're dealing with varying levels of skill, knowledge, and experience. And a decent job can be done in many instances if someone's cared about it. They've gone on and gotten some education. They've gotten some education in using and prescribing compounded bioidentical hormones. In fact, any hormones you can get are going to be a benefit.
Yeah, right. I mean,
it's not going to cover. It's not going to work for a lot of women. A lot of women have challenges with it when they're just given a few choices. And you really would love to get a specialist and contact us. That's what we do. There's states that we have providers in that are being trained and mentored.
And with the advent of telemedicine too, it's getting a little bit better now as well.
It sure is.
Yeah.
We have physicians that are in our training and residency program that cover the state of California, New York, and Florida, Colorado, cover the whole states.
Utah.
So,
yeah.
And we're one of our missions is to get it in every state. But regardless, you can find people out there, healthcare professionals who can write a prescription. That's what you need. They've got to have prescriptive power, and they've got to have something called a narcotics license, a DEA, because you want them to be prescribing you testosterone.
So I guess forgery's out of the question there, huh? That was a joke.
Anyway, I'm so sorry. I'm not remembering the initial question that's triggered.
Well, it's interesting because it ties into the next question. So the question had to do with her NP thyroid, and it's making her.
I'm so sorry. Thanks for reminding me.
Of course.
So, because midlife lower functioning thyroid is so common, in the menopause method, we include that in our expertise. The longest training program in our whole program is on thyroid. And to get thyroid right. So what I don't know, because I don't have enough information, and it's a great place to start with the hormones, because the hormones are very related to energy.
Mm-hmm.
They're very related to metabolism. You eat food, you combine it with oxygen, you produce heat and energy. Well, the inability to do that in a youthful way or in levels that are satisfactory is extremely common because we've put too much pressure on the thyroid gland and the ovaries and the adrenals over time. So a good place to start in menopause, and it's part of our initial workup, is sophisticated thyroid tests, along with our whole program around replenishing ovarian hormones. That's a good place to start in a midlife woman. However, what I don't know is I don't know what this woman's thyroid tests look like.
Right.
There's four of them that really matter: free T3, free T4, TSH, and reverse T3. These really matter. It matters, did she do a fasting test? It matters when she did her last dose. So just saying that she did NP thyroid, which is a desiccated thyroid, not my favorite anymore, coming from an animal. If you open the bottle, it smells like a barnyard for most, unless they have a very pure form of it. It's not identical to the human T3 and T4 ratio, but it's good. It's been a mainstay for decades and decades and decades, Armour thyroid. So there's not enough information there. And here's the whole deal. When someone has symptoms, the process of uncovering and dealing with them is always the same. Like, for example, in the menopause method, which is a similar method, is based on the method that I was taught in medical school, is you ask a lot of questions. We have a 12-page questionnaire that people fill out online. There are a lot of questions. Why are those questions there? Because we learn a tremendous amount about what's going on. And we get clues to what are the first important steps. And if someone's complaining of low energy and other symptoms, that's going to be up there because health in general is dependent on energy production.
That's a good clue.
Nothing works without the energy. Get constipated because your bowels don't work, your immune system doesn't work up to speed. So we address it, but the order of addressing it totally derives from that first interview. And it's very common for us to take between a half hour and 45 minutes just to review 12 pages of the questions we've asked you. From that, and from what laboratory tests have been provided at that first visit, this is how it always works. We get clues of where to begin. In a midlife woman, the most common place we begin, especially we're the menopause method. Women have sought us out for menopause issues, right? The most common place we begin is treating the loss of these powerful ovarian hormones, including thyroid, which is not an ovarian hormone, but it's a powerful hormone. We're paying attention to that right out of the gate. And we see what's achieved. And if not enough's achieved, you may have to go on to other specialists, like those who, sometimes we get a clue, oh, we need to send this woman off to have something else evaluated by a specialist. But there's always a path because healing is possible. And when you're in a situation where you're not feeling well, sometimes you lose sight of the possibility that healing is possible. And where it gets challenging is, are you willing to identify the causes of why you're not feeling well, why your energy's low? And they come down to issues of nutrition, issues of toxicity, issues of exercise, too much or too little, and issues of how you respond to the stresses of life.
Biggie.
Some people are responding in a fight or flight way that they're just draining their energy. And that what that calls for is a concerted, committed program to acquire information and tools to deal with your own emotions, your own mind, your own consciousness, your ability to make wise choices so that you're crafting a life that is serving life itself, including you.
Yes.
So it's a big world. And when there's exhaustion, for someone who really, this is what we care about, this is what we're studying, we know how to follow the bouncing ball to see what's the biology of the exhaustion. Oops. What's the emotions of the exhaustion? What's the life of the exhaustion? So big question there.
Yeah.
Better living through biochemistry? Is getting the right thyroid and ovarian dose the key to the highway? In many instances, it can make a major difference.
Oh, yeah.
Like major, and a satisfactory difference.
Yes.
In other cases, it doesn't. It's not enough. You got to go deeper and stronger.
Absolutely. And so that, trying to figure out here, this question is coming in, and I thank you very much, because we could really go off on what you were just talking about, and we have many times. This woman is saying that her OBGYN told her she cannot take compounded progesterone cream while taking her compounded estrogen cream that was prescribed by this doctor. The physician will not allow her to take the compounded progesterone with the compounded estrogen due to the physician's concern of the lining of her patient's uterus. So the questioner is saying, I was wondering your thoughts concerning this. She's okay with my taking an oral progesterone capsule, but that's a little confusing to me. Could you expound on this a bit? And that will lead me into my next question.
Well, as in many questions, these are more often the beginning and entry into a conversation in which much more is needed to be able to understand an individual woman's situation. But I am making this guess that behind what the physician is saying is the physician wants to be certain that the woman has robust and adequate levels of progesterone to balance the taking of the estrogen.
Interesting.
And it's a common thing to not be able to get enough progesterone to provide proper balance when you're taking progesterone topically. Sometimes you need to go to oral progesterone. And I'm coming down on the side of the physician. And did I hear the word OB-GYN there?
You did.
Gynecologists are really familiar with if you don't have enough progesterone, you can bleed. Because progesterone is what balances that estrogen, and so you don't get an over thickness of the endometrial lining in which you do some form of bleeding, not necessarily official menstruating. And many OB-GYNs are very savvy and know that you're going to need a lot more progesterone that can be adequately delivered to most women by topical progesterone. I love topical progesterone. I've used it my whole career in menopause, 25 years. And at the same time, I'd say 80% of the women in the menopause method, we eventually get them over to oral progesterone. Because I'm in agreement with this woman's gynecologist that you need adequate progesterone to balance the estrogen. And in most instances, you're not going to get it by applying it topically. And there's reasons why.
Interesting.
So many physicians who are knowledgeable enough about this, they're going to start patients off with 100 milligrams of oral progesterone. They don't want to see a bleed. They want to have adequate progesterone. And they know that they can't get it in topically in most, but not all instances. We have women that when they take 5 drops of our progesterone, they sleep well and they do beautifully. If they take 6 drops, it's too much. They wake up groggy. So it is possible to get too much for an individual woman topically, but it's not common. And that gynecologist is making a strong point there. And they don't want to err on the side of insufficient progesterone for a lot of good reasons. So I'm going to side with the gynecologist. I'm going to say that, yeah, correct in most every instance.
So, I have a few minutes here, and I'm going to ask you this question. Is there a difference between the kind of progesterone that you get, like, at your pharmacy, your insurance pays for it or whatever, and what is called, come to learn, micronized, which I guess is compounded out progesterone capsules? Is there a difference there?
Well, I'm going to approach it. It's a great question.
Thank you.
I'm going to approach it a little different. Progesterone was not a very popular hormone until the 80s, when a medical doctor named John Lee started pointing out to the more holistic community and to women that progesterone was really important and the lack of progesterone was really detrimental. And progesterone really got popular, and it really got popular where? In the compounded bioidentical world. And these compounding pharmacists were cranking out progesterone in just tremendous numbers because women need it. I mean, if you're a woman in your 30s, you could be getting low on progesterone. If you haven't had menstrual cramps in your 30s and all of a sudden you develop them or you start getting breast tenderness, most likely your progesterone's declining at a faster and deeper rate than your estrogen is. Remember, your hormones peak at the age 20, plus or minus a couple of years, and then they gradually decline. But the progesterone can decline earlier and deeper than the estrogen, and it's so common. And so we like to see women in their 30s get on a topical progesterone when they can get sufficient progesterone through a topical progesterone in their 30s. Women in your 30s, you may not be on this call, but hey, moms, tell your daughters in your 30s, start thinking progesterone because it's so beneficial for you.
If only I had known. Honest to God.
You can't get topical progesterone over the counter that will work in your 30s because you don't need a lot of it. Now, let's see where to go with this. Yeah, the compounding pharmacists were giving out micronized, bioidentical progesterone. They put it up on topicals, apply it to your skin, or capsules, micronized progesterone. And when I started working with progesterone, in fact, we do the same thing I've done for decades, is when I want to switch to oral progesterone, almost every woman, we start on topical. But we'll learn pretty quickly whether they're getting decent levels. And if we're not, we're going to switch to oral pretty quickly. And especially if there's a sleep issue. And what we'll do is I'll give a woman a bottle of 25 milligram micronized progesterone in capsules. If I'm going to switch to oral, I'll give her 30 of those capsules. And I'll give her 30 of 50 milligram capsules. And what we'll do is most women will start on 50 milligrams a night. Why at night? Because progesterone is the great calmer. Right. And oral progesterone or any progesterone is going to help a woman who's having sleep issues. So we always give it at night. Sometimes we give progesterone during the day if there's anxiety too. But how we start out is with 30 capsules of micronized progesterone, 25 milligrams, and 30 capsules of micronized progesterone, 50 milligrams. And most women, we start out on 50 milligrams orally at sleep time. And some women, we start off on 25 milligrams if they give signs of being special sensitive. And then we'll gradually increase that. We'll increase by 25 milligrams maybe every 3 days, maybe every 7 days. So she'll do 50 milligrams for 3 nights. And then she'll do 75 milligrams if she's not sleeping as much as she'd like to. And then we'll give her 100 milligrams. And then we'll give her 125 milligrams. We'll keep going until she gets an overdose. How do we know an overdose? She gets too calm. She'll wake up in the morning feeling groggy, like she had taken an overdose of a sleeping pill. That's how we find the right dose of oral progesterone. And once she gets to the groggy, we'll back her down by 25 milligrams, and that'll usually be the cure right there. So we're maximizing oral progesterone when we're doing it. And it's a miracle for a lot of women. I just was recently dealing with a patient who hadn't slept for 20 years.
It's a long time.
Terrible sleep.
Ugh.
And then we put her on oral progesterone, and within, I think as she said, within 3 days, she was sleeping. And now we've got her right dose. She happens to have zeroed in on 150 milligrams as her optimal dose.
What a beautiful thing.
Oh in my practice, the most common dose is somewhere between 50 milligrams and 125 milligrams. But there are outliers that need more even. So this success with progesterone did not go unnoticed. And the pharmaceutical manufacturers chose to come out with oral progesterone. And what they chose is 2 doses. They're doing oral micronized progesterone. And what they offer is 100 milligram capsules and 200 milligram capsules. And they chose those for a reason. They said that that was needed to get adequate balance so a woman wouldn't form a thicker endometrium, lining of her uterus wouldn't bleed. Well, we've done so many studies on that we found that women who are on 50 milligrams, 75 milligrams, we know that there's a wide range, but they're trying to cover the whole population. So they chose to be practical and so they could actually manufacture it, micronized progesterone, 100 milligrams and 200 milligrams. We would never be satisfied with that. We individualize these things enormously. It's at the bedrock of the menopause method, and it's the bedrock of what many physicians are doing who are dealing with compounded bioidentical hormones. We can give women any dose we want. We just write it down on a prescription pad, so to speak. Not these days, it's all electronic. But
you said
we're trying to dial in the optimal progesterone dose. And there's ways that we can tell whether it's optimal or not. So we want all those choices. I have a woman that could only tolerate 5 milligrams of progesterone.
Right.
The 100 and 200 milligram choices didn't carry the day. And these pharmaceutically manufactured progesterones are put up in peanut oil. That's what's in the capsule. Peanut oil? Oh my God, I'm just amazed that they do that they would choose peanut oil with all the peanut allergy out there. And there's a few other things in there. So if you look up what's in a micronized pharmaceutically manufactured progesterone, there's things in there that I don't like. So why don't I get the pure stuff? But if the only thing I had on the planet Earth was pharmaceutically manufactured progesterone in 2 dose strengths, I would take it. But there's, since the 1980s, compounding pharmacists have been making up these gorgeous progesterone forms in all kinds of creams and gels and capsules and micronized and all kinds of dosages. It gives the physician or nurse practitioner just endless choices about dialing it in precisely with every woman. So we do that. And there's a lot of moving parts to consider with progesterone. And the gynecologists are absolutely, they know better than anyone else that endometrial cancer exists. I'm not saying that hormones have anything to do with the cause of cancer. No, do not. Cancer has many causes. Hormones are not the causes. That's a pretty bold statement. Hormones are not the causes. But at any rate, no gynecologist is going to see a woman who's bleeding when she's 70.
Correct.
Too much dose there in most instances. Never say never. Some women need such robust levels to get their cognition back that they're actually going to have so much that they're going to menstruate. Those are very rare acceptable situations, but they are acceptable in the treatment of cognitive decline and dementia. You go where you need to go, even if that period comes back, because dementia is very, very serious and it's life-threatening, and you certainly don't get to stay at home at a certain point in dementia. So I'm wandering into many different topics there, and
they're all interesting, Dr. Rosensweet, and they're so important to all of us, really, and very appreciated. I'm gonna move us into the last question, which will give us a little bit of time, maybe, to just continue with some of these other questions. Our questioner is writing about her reverse T3 because we were talking about thyroid.
Could I interrupt you for a minute?
You may.
I just see that Sean is asking a very relevant question that I'd like to address because it's about progesterone. What if your progesterone causes you to feel depressed? Bingo. That's very relevant.
Yes.
But it's not your progesterone that's causing you to be depressed. It can easily be an overdose of progesterone.
Right. And I put those charts up, by the way, for women to see.
That's the thing about progesterone. When you got the right amount, and here's the only thing acceptable in the world of treating with hormones. The only thing that's acceptable is a woman feels better. Every way. Her mood does not worsen. If her mood worsens, something's wrong. Pilot error, folks.
Pilot error.
So if a woman gets depressed, she's on too much progesterone.
Back it down.
So these things, this is one of the great wonders of compounding. If a prescriber can come up with any milligrams that we want.
Yes.
And like I was describing earlier, like, for example, we'll start on 50 milligrams when we use oral.
Yes.
We'll start on 50 milligrams a night. And if I want to say that some sleep disturbances have a low estrogen component to them, it's really important that you sort those out. You get hot flashes in the middle of the night. This is not progesterone deficiency. But so many women need adequate progesterone. You start out on 50 milligrams, and if that doesn't help the sleep in a woman who's already got her estrogen controlled, you go up to 75 or you go up to 100. And as you increase, you can wind up with progesterone overdose symptoms. The most common one I listed, and this is what Carolyn's referring to, is this information about too much progesterone. The most common thing that happens is if a woman takes too much progesterone at night, she feels drowsy when she wakes up, or like she feels a little woozy. She feels like, oh, God, what did I do? Take a sleeping pill last night? An overdose of a sleeping pill? But that's not the only thing. Depression's one of them. Progesterone's the great calmer. Very unusual for a hormone to calm. Very useful in the treatment of anxiety. When a woman loses her progesterone, she can get anxious. When she doesn't really have, she was never the anxious type, but all of a sudden she's in menopause, she feels anxiety during the day. We'll often use progesterone during the day. However, too much progesterone is too calming. And women who have too much progesterone can feel depressed. So we use that as one of the ways that we clinically determine if there's too little or too much. And if she gets depressed from taking progesterone, it's not the progesterone, it's the dosage. Well, that's where I would go first. You never say never in medicine. There can always, I know one woman who has such severe progesterone sensitivity that she can hardly take 5 milligrams without getting some form of depression. But here's the thing. Most of the time, when something's going wrong with hormones, it's the wrong dose or the wrong balance. And that's what I'm encouraging you to do.
Is that balance.
Get that balance right. Get it dialed in right.
And it can be done.
Yes,
for sure. Yeah, definitely. So the last question I have, and we have some really nice questions that are coming up too, is that I have a reverse T3 of 22.4, and I'm absolutely exhausted all of the time. I have no idea what could be wrong. Would a reverse T3, which is a thyroid hormone, or lack of, I guess, cause fatigue?
Well, this is a good question. And yet, in order to answer it for this individual patient, there is so much more I need to know.
Got it. But
let me tell you about reverse T3.
Yeah, please.
It's a blood test, and it relates to thyroid. Now, when I'm trying to evaluate a thyroid, I would never choose to only test the reverse T3. No way. I would want to, test so many other thyroid hormones. In fact, this is what I want. And you could write this down. Every single woman in the menopause method is getting a fasting blood test. And part of what we're evaluating is thyroid. And we're using free T4 and free T3 and TSH. And then finally reverse T3. But it's those first three numbers that I get the majority of our information from. Reverse T3 tells me if it's too high, and in this I believe she didn't list the laboratory normals, but I'm gonna say that this reverse T3 is most likely within range, and it's not too low and it's not too high. But if it's in range, the main thing it tells us that she does not have too much. That's all. When reverse T3 gets too high, it tells me that the most likely thing that's happening is someone's getting overdosed with thyroid treatment.
Would that cause fatigue?
Well, it could. Yes.
Okay.
Excessive. But this woman's not getting overdosed because I don't know the reference range that she actually has, but commonly it's the 20s is for most laboratories is within the reference range. In fact, I'm pulling up a laboratory of one of the labs that does this, and I'm seeing if we have a reverse T3 in the range. Yeah, here's a lab that it's 8 to 25.
Interesting.
That's for one lab, though.
Right.
So we don't know what lab was used, and still she's within range.
Yes.
Here's what reverse T3 is. If your body is fed too much thyroid hormone, it doesn't like too much of any hormone. These hormones are too powerful. So it has the ability to take your thyroid hormone, your T3 thyroid hormone, because we're naming a couple thyroid hormones there. We're naming free T4, that's a thyroid hormone. We're naming free T3, that's a thyroid hormone, T3. Those are two of thyroid hormones. Your body has the ability to take that molecule of T3 and alter it in such a way that it doesn't work.
Oh.
And chemically, it reverses the orientation of the iodine as it's in the thyroxine molecule. And it's pretty elegant. It's just as sophisticated as anything that goes on in the body. There's so many protective mechanisms. So if you see a very high reverse T3, your body is saying, whoa, we got too much T3 going on here. We're not going to go for hyperthyroidism. That's not healthy. We're going to dismantle some of this excessive, but she doesn't have that. But what's missing when you're talking about fatigue, there are so many possibilities.
Yeah.
Hormones are a good thing to think about. Absolutely. In the workup with someone fatigued, these hormones are so powerful and so many of them animate metabolism. That means they increase your energy. And if you ain't got them, you get a low energy. So hormones are a great place to start because they're about as potent as anything that can affect energy. And thyroid hormones right up there can affect energy, and so can the rest. So can all the ovarian hormones can affect energy. Not having enough progesterone can affect, you can have less energy. Why? Because progesterone facilitates the action of thyroid hormone in its own receptor site. Give me a break. Who orchestrated this thing?
Yeah, that's crazy.
The intricacy in the ballet dance there is phenomenal. But it's a great place to start. When a woman, a middle-aged woman, is feeling fatigue, a great place to start is with the hormones. Figure them out because they're going to be low. They're going to be lower than they've been since their 20s for sure. So you might as well start with these powerful biochemicals, most of which are capable of animating metabolism. That means they're able to increase metabolism, thus the production of energy and heat. But to evaluate thyroid, we start the evaluation of the thyroid in that questionnaire. We have so many questions that directly pertain to thyroid that by the time I'm done reading that questionnaire, I got some ideas about, ooh, look at this, thyroid's squeaking here. Now, there are many, many other states that lead to fatigue. So if the hormones don't do it, I mean, there's infections, there's viral infections, there's chronic infections, there's so many things that can lead to fatigue. But in a middle-aged person, you start with the hormones. And to evaluate thyroid hormone, you can do a basal body temperature. If your basal body temperature, you stick a thermometer on your nightstand, and when you wake up in the morning before you go pee, you stick it under your arm. And if that temperature is lower than 97.4, oh, you're not producing as much heat as is optimal. And so you want to think, well, what's one of the main things that produces heat? Is what produces energy? Well, what has the most influence on energy production? As far as biochemicals goes, it's thyroid. So you look at that and you do thyroid blood tests then. When thyroid is low, nothing's working. Nothing's getting enough energy. The gut doesn't work, so you get constipated. Just for openers, you get tired and constipated. If you're tired and constipated, you want to look at thyroid hormone. Old-fashioned GPs, they understood this. They would give their middle-aged patients thyroid routinely, and the people would feel better. Why? Because they had worn down the effectiveness of their thyroid gland, because they had overtaxed it through excessive amounts of stress.
I was gonna bring up stress. Yeah.
It's not the stress. It's always a dysfunctional response to the stress that is the problem.
Well put. Yes.
So, but at any rate, Yeah, it's great to investigate thyroid, but you need a heck of a lot more information than reverse T3.
Like 4 or 5, maybe. I don't know. Learning about all this.
And the magic hour has arrived. So
Aw, I
we're going to
thought we
sign
just
off
had
for
the
today.
magic hour. This is the end of the magic hour.
Yeah. I'm going to say sayonara for now.
Sayonara? That's going
Yeah.
to say adios. So, Dr. David Rosensweet, another wonderful interview with so much appreciation always. Thank you to the ladies that have come up, men who are not brave enough yet to put their names up, and everybody. Have a really great weekend. I do believe it's Thursday. It is. And I never know at this point anymore. Don't trust me on that one. And just enjoy and have fun and laugh and be kind.
Thanks
And
for your blessings, Carolyn.
always.
Till next time. See you on Tuesday.
You got it. Sayonara.